Yeah, please.
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
A very good afternoon, everybody. We are ready to begin the online Navigate Medico CME program. CMEs are designed to update the healthcare professionals with the latest advancement in their fields. So now I would like to ask Dr. Umesh Kapil sir, Secretary NAS, to address the gathering for the welcome.
Good afternoon to all the participants, all the speakers. I'm a special welcome to Dr. Govind Makharia, the coordinator of this program. I'm most grateful to you, sir, for taking this initiative. My apologies, actually, I'm traveling out of Delhi, so some background noise is there. I must say that the Navigate Medico CME program, which has been initiated, is an humble effort of NAMS to reach the most peripheral institutions and my apologies, there's an introduction in the audio. This is a humble effort. We had a series of lectures which have been done through the Navigate Zoom activity. The main aim is to upgrade the skills of the medicos who are either planning to appear for the MD MS examination or they are trying to improve their skills. The aim is to have the best medical faculty to come and provide them state-of-art all the speakers as well as Professor Govind Makharia for helping and facilitating the National Academy of Medical Sciences. Sir, we are most grateful to you. Thank you very much. Over to you.
Professor Dr. Govind K. Makharia sir is the Governing Council member and chairman of Clinical Research Committee of World Gastroenterology Organization, which is the highest and most recognized professional organization in gastroenterology, and also as the council member Pacific Association of
Thank you for
Gastroenterology.
your kind support.
He is presently the President-elect of Indian Society of Gastroenterology, as the Secretary General of Indian Society of Gastroenterology, he initiated and nurtured many educational activities. Dr. Makharia is the member of the academic committee of ICMR, DBT, JNU, and other institutions. He has received many awards as well. He has trained 102 fellows in gastroenterology, 9 PhD students. He has published over 335 articles in index journals, 45 chapters different books, and edited a handbook on celiac disease. The H index of his publications is 55, and his publications has been cited by 13,200 times. He has been listed amongst top 2% research scientists globally, according to 2021 report. The main area of his research is celiac disease. Welcome you here, sir, and I would like to ask you to address the gathering.
Thank you, Dr. Kapil and the whole team of NAMS, because we truly appreciate that NAMS has taken this activity of educating the doctors all around the country. And this is one of the most good thing to do about medical education. So in gastroenterology, we know that 1/3 of our population have some kind of GI disorder. We thought let's focus on 5 or 6 of those disorders, which are very common in our clinical practice. And in that regards, we had last 2 lectures, one by Dr. Osadatta, as he talked about approach to dyspepsia, and also another lecture by Dr. Uday Ghosal, who dwelled upon the management strategies in those patients who have IBS and other FGIDs. So in that series, now we have a 3rd lecture today, and this lecture is on a very common disease. That's a gastroesophageal reflux disease. We all know about 15% of our population have reflux issues, who are symptomatic sometimes very often or less often. Also, we also want to focus upon the use of PPIs, which are so commonly used drugs. So with the 2 main objectives to discuss about approach to a patient with GERD and also talk about the best use of PPI. And to do this, we have a very dear colleague, Dr. Amit Datta. Amit Datta, professor at CMC Vellore, very astute clinician, a very avid researcher. And just to tell you that Dr. Datta has written a guideline on PPI, best strategy to use PPIs. So with that, I hand over to you for introducing Dr. Datta formally, and then lecture by Dr. Datta.
Dr. Amit Kumar Datta is a professor of gastroenterology at CMC Vellore. He has over 90 journal publications and 6 book chapters. He is the editor of Indian Journal of Gastroenterology. He is also the editorial board member of World Journal of Gastroenterology and GHET. His primary research areas are luminal GI disorders, advanced endoscopic imaging. He is the recipient of various awards like Shakuntala Amir Chand Prize from ICMR, Indian Society of Gastroenterology Om Prakash Memorial Award, Japanese Society of Gastroenterology Research Program Award. He is the member of Indian Society of Gastroenterology Task Forces on Dyspepsia, GERD, and H. pylori. We are very eager to listen from you, sir. I welcome you and I would request you to start the session.
Okay, so good afternoon. And first of all, I would like to thank National Academy of Medical Sciences for inviting me for this presentation. And my regards to Professor Govind Makharia, Professor Kapil, and the moderators. And I will start sharing my screen. So is my slide visible?
Yes. Yes.
So the topic of my presentation is, so I'm covering 2 topics. One is gastroesophageal reflux disease, which will be the bulk of presentation, and then a little bit on proton pump inhibitors. So we'll begin with gastroesophageal reflux disease. So what is GERD? Basically, as the name suggests, when the gastric contents reflux into esophagus and they cause symptoms which can be heartburn, regurgitation, and sometimes chest pain, and that is called GERD or gastroesophageal reflux disease. And as Dr. Govind Makharia was saying, it's a common condition in the general population. And most of the patients do not require any invasive tests. So we need to approach, if we approach them systematically, we can manage most of them with clinically and with medication. So therefore, it's a common problem. And it's important that we are aware about this condition and approach the patient in a systematic fashion. So GERD is in most situations a clinical diagnosis. And so clinical means we go by symptoms. So according to the Montreal, which is an international group, international definition, GERD is a condition that develops when the stomach contains reflux and they cause troublesome symptoms. And then we also have a definition from our own Indian Society of Gastroenterology Task Force on GERD. And what they say is that GERD is basically when you have heartburn or sour regurgitation, which occurs at least once per week and for at least 1 month. Now, small amount of reflux, infrequent reflux is common. Many of us experience it. To call it a disease, we need to quantify it by some amount of frequency as well as the duration. So it says about 1 per week for at least a month. If you look at the epidemiology of GERD, it's a very common condition, quite common in the Western countries. And India is just lags behind them at 15 to 19.9%. There are several studies from India looking at the frequency or prevalence of GERD in our population. These are both hospital-based studies as well as these are community studies. So this is one of the large studies done by the Indian Society of Gastroenterology Task Force on GERD, which looked at this at 12 centers across country in more than 3,000 patients. And what they found is that the frequency of GERD was 7.6%. It was a little bit more common in South than it was in North India. Now, this was mainly a hospital-based study. Then we have a large community-based study from South India from our center in CMC Vellore. We looked at the people in the community in 133 villages, 55 urban areas, covering more than 6,000 patients. And what we found is that here also GERD was about 8.2%. That was the prevalence of GERD, seen more commonly in urban than in rural population. So like this, there are many more studies. And in 2020, Dr. Ghoshal, who took the previous lecture, he and his team did a meta-analysis to pool the prevalence and see what is the pooled prevalence of GERD in our country. And it comes to about 15.6%. So that means almost 1 in every 6 to 7% you see in our country will have this condition. So it's a very common condition. So it's very important to be aware about this and how to approach and manage these patients appropriately. Moving on a little bit about the pathophysiology of GERD. Now, there are 3 main mechanisms. The most important is what we call it as transient lower esophageal sphincter relaxation, or TLESR. So we know that lower part of esophagus has a sphincter which is about 2 to 4 centimeters in length. When you swallow a food, the sphincter relaxes, food goes in. But when you are not swallowing, the sphincter is normally closed and it prevents the content of stomach to going into esophagus. What happens in TLESR is that without swallowing itself, the sphincter is relaxing. So it does occur as a part of physiological process few times a day. But when the frequency is higher, it can lead to reflux disease. So this is the most important mechanism for GERD. We also know that at G junction, there is an anatomical barrier for reflux. For example, you obviously have the sphincter. Part of esophagus is in the abdomen. Then you have this angle of His between the fundus and esophagus, which works like a flap valve mechanism, preventing reflux of contents. You have the diaphragmatic ligaments. All the anatomical factors form a barrier between the esophagus and stomach, preventing reflux of content. And this also prevents reflux. So when this barrier is affected, for example, by hiatus hernia or etc., then patients are prone to reflux disease. The next factor is, now what happens is if some part of stomach content does come to esophagus, then esophagus by its peristaltic movements is able to clear it and send it back into the stomach. Now when this is called basically volume clearance. If this is impaired because of some problem in the motility or some other disease, then again you are predisposed to GERD. So the main mechanisms again, increased frequency of this TLESR, that is relaxation of sphincter without swallowing, problem at the anatomical level, and impaired volume clearance. Now remember, in patients with GERD, it's not a problem of more acid secretion. Actually, acid secretion is normal in these patients. It's essentially the other factor. So the acid secretion is mostly normal in patients who have GERD. So when the acid content refluxes in the esophagus, in some patients, it leads to some damage in the mucosa in form of erosion and ulcer. I think the more recent evidence says this is more likely to be cytokine mediated rather than direct injury to acid. but the erosions and ulcerations occur only in about 20% of cases. So if you have 100 patients who have GERD, only about 20 or 25 of them will have this erosion. Rest of them will not have any erosion despite having acid reflux. So when you don't have erosion, it's called non-erosive reflux disease. And when you have erosion, it's called erosive reflux disease. So that's about the pathophysiology. Next, we move on to the risk factors. And it's very important to know about the risk factors because until we know them, we can't address them when we are going to manage the patient. So we need to know risk factors to identify it so that we can manage our patients appropriately. And the important ones are obesity, hiatus hernia, smoking, and tobacco consumption. As our age increases, there is a higher risk of getting GERD. Dietary factors actually very frequently implicated, but the association is not very consistent and it's weak. We'll discuss about it later. There are also genetic factors. And sometimes some patients undergo surgery where the sphincter is cut, like happens in patients with echinacea cardia, or patients with scleroderma where the esophagus motility is not good, the volume clearance is impaired. Pregnancy, these factors also predispose to GERD, but the main ones again, obesity, hiatus hernia, smoking, and tobacco consumption. And there are several studies which have linked higher BMI with GERD. In the same way, what happens in hiatus hernia, I was just talking about the anatomical barrier at G junction, how it helps in preventing reflux. Now in hiatus, usually in normal people, part of esophagus is actually inside the abdominal cavity, but in hiatus hernia, the stomach actually herniates the diaphragm and part of stomach comes into the thoracic cavity. So when this migrates a bit up, the diaphragmatic support is impaired, the ligaments are all not there, the sphincter also gets weakened. And because of this disruption of the anatomical barrier between the esophagus and stomach, this predisposes to reflux disease. So in this picture, you see a normal G junction, the esophageal mucosa and the junction here. But in this patient, you can see the gastric mucosa from the esophagus itself because this part of stomach has actually herniated into the thoracic cavity. Diet, as I was saying, frequently talked about, but the association is a bit weak and inconsistent. If you look at data from our own country, it's quite variable. The one food item which has been sort of linked in most studies is non-vegetarian food item, at least from 3 studies, that non-veg item somehow predisposes to reflux disease. So that was about the definition that GERD is a clinical condition and we define it based on clinical symptoms. We discussed about the epidemiology, that it affects about 15% of our population. Then we discussed about the pathophysiological features, what predisposes to GERD, and the risk factors. Next, we go on to the clinical features, which is a very important part because as I told you, if you take a good history examination, then in many patients, you won't have to do any invasive investigation, okay? So in clinical features, we first ask about the nature of the main symptom of GERD, that is heartburn, regurgitation, chest pain. That is how severe are the symptoms, how frequently do they occur, how long they have been happening. Are these symptoms related to any meal, any posture, etc.? Apart from these common symptoms, these patients may also have water brash is basically sudden appearance of saliva in the mouth. They can have hiccups, they can have nausea. And uncommonly, they may also have odynophagia, which is pain during swallowing. Some patients with long-standing GERD can also go on to develop complications like bleeding or stricture. Stricture can give rise to dysphagia. Sometimes these patients can have dysphagia even without a stricture because GERD can also sometimes lead to dysmotility of esophagus. So again, the main symptoms, we need to know the nature, the severity, frequency, and duration, ask for other symptoms as well as complication. Now, apart from symptom in the esophagus due to acid reflux, there are also extraesophageal symptoms associated with GERD. And one mechanism is that the acid reflux can reach up to the larynx and it can also go into the lungs. Second mechanism is it can stimulate the vagus nerve and it can be a vagally mediated phenomenon as well. And these include laryngopharyngeal reflux symptoms, which patient can have cough or hoarseness or irritation in the throat. Patient may have asthma, aspiration, pneumonia, bronchitis, etc. Reflux in the mouth can lead to dental erosions. You can have otitis media, and patients often can get sleep disturbance. Now, one very important thing to remember here is that for these symptoms, GERD is not the only cause. Okay, so therefore, when you have patients with these symptoms, make sure that we are not attributing all the time everything to GERD. Other things are looked into. So when you have a cough, make sure there's no history of smoking. Chest X-ray is normal. Other things are not there. And this is one area of also misuse of PPI because when you have these symptoms, we attribute to GERD without any investigation, and then patient gets treated actually. So remember, these symptoms are known, but there are other reasons as well, and we should be looking for those factors actually. So once we have looked at the clinical symptoms, the extraesophageal symptoms, we also need to look at what risk factor the patient has so that we can address them when we are treating these patients, like obesity, smoking, etc. Also very important to take a good medication history, because these medications like potassium chloride and bisphosphonate, etc., can sometimes get stuck in the esophagus and cause ulceration, and you may have symptoms of GERD. Now, another very important group part of history which I have colored in red here is on alarm symptom. Now, this is very, very important part, and this is like we have to ask for these symptoms when patients come to us with reflux disease. This includes dysphagia, which is difficult in swallowing, weight loss, GI bleed, vomiting, anemia. Now, this is important because if somebody has these symptoms, then these patients require more investigation than patients who do not have the symptom. I will be discussing this later. So always very important to ask for these alarm features. Clinical examination is generally normal, but still it's very important because you may pick up findings like pallor, lymphadenopathy, which can point towards a serious underlying condition. So we should do a good general examination and a systemic examination. Also remember that when patient comes to us with reflux symptoms, we are diagnosing GERD. It does not always occur in isolation. In fact, a significant proportion of patients who have GERD actually may also have coexisting functional dyspepsia. They may also have IBS. These topics already have been covered in previous lectures. So therefore, you need to ask for a history of these conditions as well, because if they have these conditions, then they have to be managed as well. Okay. Little bit about the quality of life. Now, quality of life is something we know that GERD has a significant impact on quality of life. And obviously, these can be assessed where there are questionnaires to assess the quality of life. And in our busy OPD practice, we really don't have much time to go into the quality of life. It's mostly a research tool, but still, it's important to know about these parameters. And for some patients, it may be helpful. So it's good to be aware about this quality of life parameters which are available for GERD. Okay, so once we have done a good clinical assessment, we have taken a good history, we have examined the patient, we've asked about the symptoms, the complications, the risk factors, alarm features, then we are now ready to decide how should we proceed further in these patients actually, okay? So this is the summary of the approach. So patient has come to you with symptom of GERD, you have asked for alarm features, and you assess patient's age. If the patient does not have any alarm features, and if the patient is less than 55 years of age, then you don't need to do any endoscopy. You can straight away go for trial of PPI. This is also called as a PPI test. So these patients without alarm features, young patients do not require upper GI endoscopy for their symptoms. When you give a PPI and if the patients are responding, which happens in about 80% of cases, then you're pretty much certain with about almost 80% sensitivity that this patient has GERD. And then you can continue therapy for about 4 to 8 weeks maximum and then stop therapy. And this route actually, almost 80 to 85% of your patients will fall in this pathway. That is, they don't require endoscopy, you can straight away go this thing. If the patient has alarm features, as I told you, dysphagia, vomiting, GI, etc., but if the patient is more than 55 years of age, as we grow older, the chance of disease, organic disease becomes higher. So if somebody is more than 55 years of age, somebody has alarm features, these patients require upper GI endoscopy, okay? In upper GI endoscopy, it has twofold purpose. It can help you to diagnose GERD by showing esophagitis, erosions, etc. It also helps you to exclude other conditions like infection, neoplasia, etc. during endoscopy. If endoscopy is also normal and patient has not responded to PPI, then we have to go for what is called a pH study, which assesses if there's an acid reflux by checking the pH of the reflux content. This is considered the gold standard test, but it's not that freely available, and that's why it's not required in all the patients. If this study is positive, then you call the patient as having GERD, but if it is negative, then you can confidently say the patient does not have GERD because your PPI test is not working, your endoscopy is normal, and pH study is negative. Then the cause of symptoms, there are other cause of symptoms as well, like functional heartburn, movement disorder of esophagus, other conditions, etc. So again, just to sort of reiterate, these are the three main things we do with the patient. Most patients, young patient, no alarm features, we go for PPI test, and if they are responding, we manage them as GERD. If this test fails or if the patient has alarm features more than 55 years of age, we go for endoscopy. If this is normal, we go for pH test. So these are the three main things we have in terms of our diagnostic armamentarium. If this is all normal, then the patient does not have GERD or think of other conditions. And we'll discuss these three briefly. So why I'm talking so much about the PPI test? Because there are so many studies in literature which has shown the benefit of this particular method. There's, in fact, a recent meta-analysis published, I think as early as in April this year, showed that it has a sensitivity of about 79, so close to 80% sensitivity. And therefore, this is a cost-effective measure of managing these patients. Moving to endoscopy, as I told you, if somebody has alarm features and somebody has not responded to PPI, we go for endoscopy. In the Western country, they also say if somebody has a high risk of Barrett's esophagus, we should go. For Barrett's, we are still in the stage of trying to make our consensus because we really lack good amount of epidemiological data. But in the West, they also do endoscopy if somebody, which is like somebody has a long-standing GERD, more than 50 years of age, somebody is obese, somebody has a family history of Barrett's or esophageal cancer, they will subject them to endoscopy as well. But at least for us, remember, alarm features, not respond to PPI, we should go for endoscopy. Now, one very important thing to remember is that when you do endoscopy, in only about 15 to 25% of patients, you're going to find something like erosion for a GERD. In the remaining patients, esophagus will be normal. So they will be having what is called as a non-erosive disease or some other condition. So we don't find erosive disease that frequently. And also when somebody gets a proton pump inhibitor, then the frequency becomes even lower. Still, it's a very important test to do because you do diagnose this many patients on endoscopy. And another very important benefit of endoscopy is that it also helps you to look at other conditions which can give reflux symptoms like infection. It can be herpes infection, Candida infection, neoplasm. Sometimes you may have piloesophagitis, eosinophilic. So it helps you to exclude these conditions and also diagnose in certain proportion of patients. I'll just show you some pictures of endo. This is a picture of patient with reflux symptoms, but on examination in endoscopy, this is the lower esophagus and the GE junction is normal. So this patient basically has non-erosive reflux disease. In this picture, you see some small ulcerations in this patient. This is a case of mild esophagitis, which is what is most commonly among patients who have erosive disease. Mild disease is much more common than severe disease. Okay. And in some patients, you can have these extensive ulcerations, large ulcerations. These are the patients who have, but this is for only a small proportion of patients who have severe esophagitis. In long-standing reflux patients, the stratified squamous epithelial mucosa can become intestinal type columnar, what we call it as a Barrett's, because of long-standing exposure to acid and injury. They can be a metaplastic change, and the Barrett's, this is how it appears, the salmon or pink-colored mucosa in the lower esophagus in these patients with long-standing reflux. Sometimes prolonged reflux and ulceration can lead to injury and healing and then fibrosis and can lead to stricture formation. So these patients, as you can see, there's a stricture in the lower esophagus, and these patients can present to you with history of dysphagia and weight loss. This is data from our own center, and when we looked at the endoscopy in more than 500 patients with GERD, we found that erosive disease was only present in about 9% of patients. Obviously, ours is a tertiary care referral hospital, and many patients have already taken PPI before they come. So when you take PPI, then obviously these lesions will heal and the less chance of finding erosive disease. But just to impress upon the fact that endoscopy will be normal in many patients, but in 15 to 25% of patients, you will find features of erosive esophagitis. If endoscopy is normal and the patient has not responded to PPI, then we have to go to the pH study. A pH study is the gold standard test, as I was telling. So what happens? So what we do in conventional pH study is we pass a catheter to the nose up to the stomach. There is a probe in the stomach and there is a probe in the lower esophagus. The probe in the stomach basically, so this probe, so whenever the acid content in the stomach refluxes into the esophagus, the probe here will detect a dip or a drop in the pH. And we do it for 24 hours to see how much time, how many times and for how much time this dip in pH is happening here. Actually. That's what we do with conventional pH study. We put the probe and we measure the pH for 24 hours. Now, there are newer techniques like wireless capsule, where instead of putting a catheter to the nose, which may be cumbersome, you just attach a capsule device here. The patient doesn't have anything coming out of his nose. And this can be kept for 48 to 96 hours. This gives you, so the more longer you study, the more likely you're going to diagnose. But this is very expensive and not really available. What we do mostly in our patients in India is we do this pH study. If the endoscopy is normal or they have not responded to pHs thing actually, okay? Now, another thing I would like to mention here is that when we talk about reflux disease, we are not mostly talking about acid reflux disease. But in some patients, even a non-acid, that is a liquid which is coming from stomach to the esophagus, which is not acidic, can also give rise to symptoms. This is called as non-acid reflux. Now, a pH study is not going to pick up something which is non-acidic. So therefore, now there are technologies which can pick up any liquid, whether it's acidic or non-acidic. And this is done by a device called impedance device. And now more recently, the devices of pH which we have, they come integrated with both pH as well as impedance in same catheter. So you can see this catheter, there is a pH probe. It also has the impedance probe. So pH probe measures acidic reflux. Impedance probe measures any liquid coming will get measured by the impedance machine actually. So how do we diagnose GERD on this pH and impedance study? Now, in a normal person, in a 24-hour period, up to 4% of time in a 24 hours period, acid exposure is considered, less than 4% is considered normal. If it is more than 4% in a 24-hour period, then it is abnormal. If the number of episodes are more and there are other parameters as well, again, which we won't go into detail, then we diagnose as GERD. So basically amount of acid exposure, frequency, etc. This is one example of the manometry and impedance recording, pH and impedance of one of our patients. So this is the esophageal probe, this is the gastric probe. Now a pH of below 4 is considered to be for acidic reflux. So if you can see the patient, the pH was okay. Suddenly at this time point, the pH dips below 4, this is an acid reflux. Another reflux here, multiple reflux episodes here. So this patient, when we saw the reading, he had 71 reflux, of which 36 were acidic, but he also had 35 non-acidic reflux. So if we didn't do impedance, we'll miss it. And recent data is showing that having an impedance device actually helps you to diagnose 20% more cases of reflux than having pH study alone. Anyway, so that was about the main test, the PPI test. Then we had the endoscopy, and then we had the pH, which is the gold standard. Now, you often hear about radiological studies, and you'll say barium swallow, barium study showing reflux of content in from the stomach esophagus. But remember, the radiological, that is the barium or gastrographin studies, are not very accurate to diagnose GERD. We seldom use them in a clinical practice because they often find reflux in a lot of healthy subjects as well. So you're going to do a lot of overdiagnosis of GERD if you use this radiological study. It's good in patients who have severe symptoms, or if you want to demonstrate hiatus hernia. But if you only have endoscopy, which can pick up this hiatus hernia, you have a pH study, then we don't need the radiological test. So it's not routinely done, but maybe in select setting, if endoscopy not available, you may do this test. But remember, it's a lot of false positive rate with radiological studies. That's why I didn't mention it in the algorithm. Okay, so we have now discussed about the clinical features and also the investigation, about the PPI test, about endoscopy, about the pH study. Now we move on to the how do we treat the patients with GERD when we see them in our clinic. Now the 4 main aspects of management. One is lifestyle, weight reduction, dietary measures, acid suppression, which is the cornerstone of therapy, surgical management, and endoscopy management. Again, for close to 90% of patients you will see in your practice, these 2 are enough. Only a small group of patients will require surgical or endoscopic therapy. Okay. So first we talk about the diet and the lifestyle measures. And as I said, obesity is a risk factor for GERD. So if somebody has got a high BMI, we should ask the patient, ask them to have reduced the weight. That's very helpful. If somebody is smoking, we should tell them to stop smoking. Elevating the head end of bed by 6 to 8 inches can be also helpful. What it does is that it prevents the gastric content from refluxing due to the effect of gravity. So it prevents the upward movement of the gastric content if you elevate the head end of bed. Also, when we take a meal, there is gastric secretion, there is food content in the stomach. So if you have a stomach which is full of food and acid, if you lie down, there is a higher risk of acid refluxing. So therefore, they say that once you have taken a meal, then at least for 3 hours, you should avoid going into the supine posture. This is important, especially in the night time, because some people will take the dinner and go to bed immediately. So this is simple advice can be quite helpful in patients with GERD, that they should avoid supine position for 3 hours after meal. Dietary factor, since the evidence is a bit inconsistent and weak, what I do in my practice is I tell the patients that, are there any food items which are triggering symptoms in you? And if they tell us this is giving symptom, I just tell them to avoid those items. So the simplest way is ask the patient what triggers symptom, and they can avoid those items. In addition, things like carbonated beverages and citrus fruits have acidic content and they can promote. So I tell them to avoid these things. Fatty foods and chocolatey items also relax the lower esophageal sphincter, and we can tell them to avoid it. But remember, most important is avoiding foods which are triggering symptom. Okay. So this was the diet and the lifestyle measures. Moving on to the medical measures, initially we had the antacids, then subsequently we had the H2RAs. Then we had the PPIs, which were got available in the late 80s, which are now the cornerstone of therapy. And more recently, we also have this PCAB, which is the potassium competitive acid blocker. These are more potent than PPIs, but they are available only in few countries. And whether having a higher potency means better symptom relief is not yet clear. So we still use PPIs as the most common drug for GERD. Most patients with GERD will show response to acid suppression with PPIs. PPIs have been shown to be better than H2RAs. Usually give it for about 4 weeks, maximum 8 weeks. Don't give beyond 8 weeks. And once they have responded, then you try to stop the therapy after that. Don't give them indefinitely long-term PPI. Once they are better, stop the therapy. Having said that, H2RAs are still not out of thing. They are still very good drugs. And for patients whose symptoms are not very frequent, once in a while symptoms, those patients, we still use H2RAs because they are also very safe drug. They've been available for a long time. They are cheaper and they are safe. So both PPIs and H2RAs are better, but PPIs have more efficacy than H2RAs to be used. Okay, and use them for a defined period of time. And again, shown by Cochrane review that both PPI and H2RAs are better. They are better than prokinetics, which I'll be discussing later for GERD. So there are so many PPIs available in the market. You have esomeprazole, pantoprazole, omeprazole, rabeprazole, etc. Which one should we choose and what dose should we choose? So if you look at the pharmacokinetic profile of these drugs, basically what we are looking at, that in a 24-hour period, how much time are they able to maintain a stomach pH of above 4? And if you look at most of the PPIs, the efficacy is quite same. This thing in pink is basically not PPI. This is basically the PCAB I was talking about, the potassium competitive acid blocker, vonoprazan. This is not a PPI. This is actually a very potent acid suppression, but not freely available, and we don't have much data on this. So this is just for comparison. But our PPIs are all here, and you can see they all have similar efficacy in terms of acid secretion inhibition. And when you increase the dose from once daily to double dose, it doesn't lead to too much of incremental benefit. So therefore, for practical purposes, you can use any PPI you are comfortable with and use it in a standard once daily dosing. Don't use it in double dosing straight away. Those patients who don't respond to once daily after maybe some time, those patients you can go to twice. But starting should always be once daily dose, and any PPI is fine. That's what I would suggest. Okay. And it's not enough just to write PPI prescription. Tell the patient how to take the medicine. So it should be taken 30 to 60 minutes before meal. Make sure the patient is complying with your instructions. And occasionally when patients don't respond, you can either split the dose. For example, somebody is on esomeprazole 40 once daily. You can make it 20 in the morning, 20 in the night. Or you can, in some cases, increase the dose, but that is only in a select group of patients. Okay. Taking before meal and ensuring compliance are very important to have successful therapeutic outcome. Now, patients who have GERD symptoms, obviously you treat them, they become better. A proportion of them are going to have recurrence of symptoms when you follow them up. So you have to follow them up. So what do we do? Because symptoms are going to recur in some patients, should we continue treatment or should we give it when the symptoms recur? So when you give the treatment when the symptoms recur, is called on-demand therapy. Now, there is enough data in the literature, 8 studies, a meta-analysis recently shown that whether you give continuous or whether you give intermittent, that is on demand, the efficacy is similar. So therefore, give it on demand. The 2 benefits are, one is that patient doesn't have to spend money on taking PPI every day. And more importantly, you also avoid the side effects of using long-term PPI. So for mild GERD, non-erosive reflux disease, give initial therapy, stop the therapy, and then give it on demand whenever the patient has a recurrence of symptoms. Don't give continuous therapy. But if somebody has a severe erosive esophagitis or a peptic stricture, then these are the patients who require long-term PPI. Apart from the acid suppression, there are other medications also like alginates, which can be used as an add-on therapy. Now, alginates form a bit of a barrier like a raft at the G junction, preventing acid reflux. They can be used as an add-on therapy for postprandial reflux symptoms. Prokinetics, again, prokinetics are very commonly prescribed for GERD, but if you look at the literature, the evidence for their efficacy is quite limited. So prokinetics are not as good as PPI, not as good as H2RAs, and their side effect profile is more than what it is for a PPI. Therefore, these are drugs which we should use only in select patients with GERD, especially patients who have volume reflux or when they have something suggestive of delayed gastric emptying, but not like a routine. Because nowadays we have a lot of these combination therapies of PPI and prokinetics in the market, and then we prescribe them. But remember, prokinetics are not very helpful, and please be aware of the side effects of drugs. Now, what about medicines which affect the TLESR, which I was talking as one of the main mechanism of reflux, the medicines which affect the transient lower esophageal sphincter relaxation. So we have this medicine, baclofen, which is a GABA B agonist, which does reduce that and it helps with reflux symptoms. But unfortunately, this has a lot of CNS side effects like drowsiness, dizziness, nausea. So we can only use it for a very short course and only in patients who have not responded to. But we do use it in our patients who don't respond to PPI and for a short course. So that was the two main aspects of management, the lifestyle, weight reduction, dietary measures, and acid suppression. This will be sufficient in most of your patients. A small number of patients would also require the next step, which is surgical or endoscopic therapy. Now, in the pathophysiology, we discussed about the TLESR, the anatomical barrier, and volume clearance. Medications are only helping in reducing the acid secretion or neutralizing it. They don't do anything to the barrier function. So if somebody is not responding to acid suppression, then in those patients, we have to think how we can make the G junction barrier strong. How can we tighten this barrier? And this is what is done in surgical therapy, or more recently, we have endoscopic therapy as a less invasive option, which also aims to strengthen this barrier. So who are the patients who need surgical intervention? Or patients who have responded to PPI, but they don't want to take medicine. They are not complying with medication therapy. Patients who are experiencing side effect of therapy. Those who are having regurgitation or volume reflux as the main symptoms. Patients with very large hiatus hernia with a lot of anatomical disruption. Severe esophagitis, not respond to PPI. In all this group, you see severe esophagitis, first try PPI. Even hiatus hernia, first you try PPI. If regurgitation still, so all these things, you are going to still try PPI first therapy. Only if they're not responding, you go to surgery, or if they're having side effect of therapy, or if they are not complying to therapy. And then you have the patients with refractory GERD, that is, you still have abnormal pH study despite being on PPI. There you may need to do a surgical intervention. So what the surgical intervention does is that it strengthens the barrier. The standard surgery is called the fundoplication surgery. It strengthens the G-junction barrier by wrapping the fundus around the esophagus. The classical surgery was the Nissen fundoplication, where you do a 360-degree wrap, so to tighten the barrier. Then we have Toupet, which is 270-degree wrap, and the Door fundoplication, which is 180-degree wrap. So when you make a wrap, you try to prevent the reflux of content from stomach into esophagus. Now remember, the tighter wrap you have, then you run the risk of food not getting into from esophagus stomach, a patient may develop dysphagia. Sometimes if there is a gas buildup in the stomach, normally we will be belching to bring out the gas. These patients will find it difficult to bring out the gas. That's called a gas bloat syndrome. So you have a higher risk. So you have a much better control of acid reflux, but you run the risk of having difficulty in swallowing and the gas bloat. In these procedures, the risk of dysphagia and gas bloat is lower, but then the control of reflux is not as good as it is in the cell. However, this problem it happens only in a small group. So still, it really varies on the surgeon's choice what procedure they want to do. Now, one important thing you should remember is that when somebody is going for surgery for GERD, in those patients, clinical diagnosis is not sufficient. You need to confirm GERD by endoscopy and pH study. Sometimes they may also need esophageal surgeons also want to know how the esophagus is moving, what is the motility by doing a manometry. So they need a proper full workup with these investigations before you subject surgery. We can't just send them based on clinical diagnosis of GERD. And also remember, the surgery does not guarantee that 100% patients will be free. They won't need PPI for the rest of the life, because data is showing that after about 6 to 8 years, many patients go back on PPI therapy. And for this reason, surgery, you have to really, when you decide on surgical therapy, you have to be careful, make a decision with the patient, let them know the pros and cons, and then make a decision. Apart from the fundoplication, there are other methods of strengthening the barrier, like you have this magnetic sphincter device, which is attached in the lower area. You also have pacing device, the pacemaker attached to the abdominal wall. And this pacemaker will stimulate the sphincter and cause contraction of the esophagus and strengthen the barrier. But the experience is not as good as it is with the fundoplication surgery. Now, being a gastroenterologist, I also want to mention about this endoscopic management of GERD, which are now emerging as a less invasive and promising options for management of GERD. Since it's a relatively newer technique and we don't have that much of experience, currently the choice of patient has to be very important. We don't choose severe GERD or a big hiatus hernia patient or a Barrett's patient for this thing. We only choose patients who have a small hernia, who don't have severe disease, who don't have any stricture or Barrett's for endoscopic therapy. Now, there are different types of endoscopic therapy available. We also have endoscopy. So the same fundoplication done by the surgeons, we can do endoscopically itself. We can plicate the fundus mucosa to esophagus. There are different devices, like you have the GERD-X, the Muse, and the TRIP device. We also have the radiofrequency ablation. You apply radiofrequency energy to the lower esophageal sphincter, and this will strengthen the sphincter. Then we have the mucosal ablation techniques, what's called the ARM or ARMA. This is the G junction view from the stomach in the retroflexion. You resect the mucosa around the G junction. Once this resected area heals with scarring, this is going to tighten this area, and then you are going to have reflex. But all these things, we still need more data to be sure that these are, especially long-term data, is still required. So what is better? Surgical thing is better, endoscopic thing is better. Surgery has been there for a long time. It's a well-tested and tried strategy. There are no head-to-head comparisons between surgery and endoscopy, but there's a network meta-analysis which showed that in many of the parameters like LES pressure improvement, quality of life improvement, healing of esophagitis, the efficacy is similar. But when you talk about reduction of the acid content in the esophagus, that is amount of time in 24-hour period, the pH is less this thing. It's more in the surgical arm actually. Now that was about the management. We spoke about the lifestyle and medical management, which is sufficient for most patients. A select group of patients we need to send for surgery or endoscopy. Little bit about the complications of GERD. The one complication which can happen is called Barrett's, which happens in 5 to 10% of cases. Some patients may also present with GI bleed, and in less than 1% of patients we may see a stricture developing. What is Barrett's? Barrett's is essentially when you have the stratified squamous epithelium here, which changes into columnar epithelium. So this is basically metaplasia of stratified squamous columnar. The importance of Barrett's lies in the fact is that in some patients, this can progress to dysplasia, and it can also progress to adenocarcinoma. So once you have somebody with Barrett's esophagus, they need to be on a surveillance endoscopy program so that we can detect at this stage before they go into carcinoma. If you detect dysplasia and treat it, you can prevent the progression to carcinoma. And Barrett's occurs in about 5 to 10% of patients with GERD. This is an example of a Barrett's esophagus on endoscopy. This is the gastric mucosal fold. Find out which area has dysplasia, but now we have technology which is called image enhanced endoscopy, which can actually say that which area has got dysplasia by looking at the picture directly. So for example, in this image, you see everything is normal, there's no dysplasia. But if you look at this picture, this is a white light, everything looks same. But when you put the image enhancement, you can straight away see this area has got some irregular appearance, abnormal appearance. And this patient, we can take a biopsy and confirm dysplasia. So now we have better tools to detect and manage dysplasia. Before completing the section on GERD, I just want to cover these 3 topics which are commonly linked to GERD. First is non-cardiac chest pain. Non-cardiac chest pain is a common condition again in the community. Patients are having chest pain like the way they have it in cardiac disease. They'll have retrosternal chest pain, which can sometimes even radiate to the neck and the arm. But the patient does not have coronary artery disease. So very, very important. Before you call somebody non-cardiac, make sure that his coronaries have been evaluated and it is normal. This condition can have an impact on quality of life, and these patients undergo extensive tests to look for any cardiac cause, GI cause, pulmonary cause, etc. Among the GI cause, GERD is probably the most frequent cause of non-cardiac chest pain, and therefore some of these patients may have to be evaluated in the same patients we do it for GERD. Eosinophilic esophagitis is a condition which is now getting more and more common in the Western countries. We're also seeing it in our country. In fact, Dr. Govind and colleague from AIMS have published their experience on this condition some time ago. Now, these patients can present to you with reflux symptoms. In addition, they may also have symptoms of dysphagia or food impaction. Essentially, in this condition, the esophageal mucosa is infiltrated with eosinophils. So when you take a biopsy, you'll find more eosinophil, more than 15 per high power field on biopsy. So therefore, it is important to be aware about this condition. Patients with GERD who are having reflux symptoms, who also have dysphagia and who are not responding to PPI, the history of allergy, history of atopy, suspect this condition and refer them to a gastroenterologist for endoscopy and midesophageal biopsy. Finally, functional heartburn. Now, in this condition, patient has symptoms of GERD, but all your investigations, that is your PPI test is negative, the PPI, there's no response. You have done the endoscopy is normal. You have done the pH study is normal. Patient does not have any other dysmotility, any other cause. So everything is normal. Patient is still having symptom. This is called functional heartburn by the functional heartburn. These patients actually, in these patients, you need to give them a neuromodulator like amitriptyline, etc. for response because they won't respond to your usual PPI. So therefore, patients with heartburn, who don't respond to PPI therapy. If things are normal, then you have to consider it as a functional heartburn and treat them with a neuromodulators, etc. So again, I just want to now summarize my thing on GERD before I move on to the PPI. Ask about the symptoms of GERD. If there are no alarm features, less than 55 years age, go for PPI test straight away. And if they respond, no further tests required, manage them as GERD. If there are alarm features, more than 55 years of age, not respond to PPI, go for endoscopy. If endoscopy is normal, PPI test is failed, you go for pH study. If this is also negative, then patient does not have GERD, then you have to consider other conditions. Management-wise, you have dietary, lifestyle, and PPI and acid suppression, the main measures. Some patients may require surgical or endoscopic therapy. Should be aware about the complications like Barrett's. They can develop GI bleed. They can be sometimes stricture. And also remember the other conditions like functional heartburn, eosinophilic esophagitis, which can mimic GERD, but they need to be managed differently. The Indian Society of Gastroenterology a few years ago has published a very comprehensive statement and guidelines on GERD, and it has taken Indian perspective into account. So for those of you who want to read more about this condition, I would suggest reading this guideline by our society on GERD. So that was about GERD. Now a quick 15-minute presentation on proton pump inhibitor. So proton pump inhibitors have been there for a while. The first one actually, which was discovered, was omeprazole, but this drug had adverse effects on thyroid, thymus, etc. So it could not get released in the market. The drug which was successfully released was omeprazole, which was discovered in 1979. Took about another 7 to 8 years before it could get into the market in the late 80s. Little bit about the pharmacology. These are the PPIs are weak bases, and therefore they accumulate in the acidic environment in the stomach. They all have a benzimidazole ring linked to a pyridine ring. And the PPIs which we take in are prodrugs actually. Once inside the body, they get converted to a sulfonamide form, which is the active form. And this sulfonamide form of PPI is the one which binds to the hydrogen potassium ATPase, which we call as the proton pump. And once it binds to them, it leads to irreversible inhibition of the pump. So they have a very short half-life in the blood, but once they are bound to the proton pump after binding, their effect is long-lasting. The proton pump is inhibited for its lifespan. Okay, and that's why these drugs don't need to be, most of them are effective in once daily dosing. They are also metabolized by cytochrome P450 system in the liver, and therefore you need to keep in mind the interactions with drugs which have similar metabolism pathways. So as I told you, PPI, basically this is the hydrogen potassium ATP of the proton pump. This is what gets inhibited by the PPI. And this is the final common pathway for acid secretion, whether it's stimulation from gastrin, whether acetylcholine or whether H2R, all of them finally they have to work through this pathway. So this PPI, since it is acting in the final common pathway, that is why it is such a potent acid suppression more than what an H2RA, which only works on this receptor. And these pumps are in much higher concentration here in the fasting state, and that is why the drugs should be given in the fasting state. Which I told in my earlier part of presentation, there are many PPIs available. They have some amount of difference in pharmacokinetic profile, but clinical efficacy is virtually same. So you can use anyone which you are comfortable with, okay? And to be taken in fasting, and be aware of the interactions that can occur with drugs which are metabolized by cytochrome P450 system. So PPIs have been wonderful drugs. They have revolutionized the management of acid-related disorders. They're very effective drugs, generally good safety profile. But because of the easy availability and application in multiple scenarios, the overuse is quite rampant and across all levels of healthcare. And so more and more adverse effects are now being reported for the use of PPI. So therefore, there is a need for PPI stewardship or a judicious use of PPI. So with this background, the Indian Society of Gastroenterology, under the leadership of Dr. Govind Makharia, who took the main initiative in this, they brought out this guidelines on optimizing the use of PPI, what we call it as a PPI stewardship. And the experts from all over the country, we got together and we followed a modified Delphi process. And we identified the problem areas and we made recommendations on rational use of PPIs actually. So again, this is something which I would suggest all of you to read and refer to, because PPIs are used by all of us for different conditions across specialties. And this gives a very comprehensive overview of where to use PPI, how long to use, what are the side effect profile, etc. So what we realized is that inappropriate use of PPI is very common in clinical practice. And therefore, when you see somebody on PPI, you try to see whether he really needs a PPI. If not, then you should stop the PPI. And this again, we are talking from evidence. There are so many studies in literature which talk about overuse of PPI. These are some of the studies, including those from India. And what is striking is if you look at the percentage of overuse of PPI, it's more than 50% in most of the studies. So it's like quite a significant amount of overuse. This is one set of studies. This is another set of studies showing similar findings. So therefore, a lot of overuse of PPI is happening, and we need to be really aware of this fact and try to cut down the appropriate use of PPI. So first we'll talk about what are the main indications for using PPI. One of them already we have discussed in my presentation, that is GERD or gastroesophageal reflux disease. The next common indication is dyspepsia. Dyspepsia is again a very common condition we see in our practice. Upper abdominal discomfort, bloating, gas, epigastric burning, etc. These patients, again, PPI is good, but should be used for only 2 to 4 weeks in a standard dose. Don't use high dose, don't use for a longer duration. Which is again shown by data from a Cochrane review where they looked at 18 studies. PPI is a good drug, better than placebo for dyspepsia. But the standard dose has similar efficacy as high dose. So standard dose is sufficient. Usually most trials have covered 2 to 8 weeks, mostly up to 4 weeks. So don't give it more than 4 weeks, rarely more than 8 weeks. Then H. pylori, then we know PPIs are a part. For H. pylori, we need a combination therapy to eradicate H. pylori, and PPIs are an integral part of H. pylori therapy. This is peptic ulcer disease. This is one condition where PPIs have really made a drastic change in the management. In the past, we used to hear about patients undergoing vagotomy, gastrojejunostomy, etc. for peptic ulcer disease. These are very, very uncommon currently because PPIs have taken care of the disease so well. Seldom patients now need to go for any surgical intervention. So if somebody has a peptic ulcer disease, PPIs are very good in healing the ulcer. Obviously, you also look for H. pylori because H. pylori is an important cause of ulcer. If there is H. pylori, you treat it, and then after that, you may need to give 2 weeks of more PPI for duodenal ulcer and 4 weeks of more PPI for gastric ulcer. So those were the main indications: GERD, dyspepsia, H. pylori eradication, and for peptic ulcer disease. We also use PPI commonly as prophylaxis. We want to prevent the side effect of the drugs which can cause ulcerations or GI bleed, which includes antiplatelets, anticoagulants, steroid, etc. But remember, everybody who's taking this medicine does not require a prophylaxis. You have to look at the situation, scenario, the risk factor, and then decide who needs these drugs. So for example, if somebody is taking 2 antiplatelets, yes, you should give prophylaxis. But if somebody is taking only 1 antiplatelet, then he should also have some more risk factors before you give PPI. Using single antiplatelet alone without a risk factor, PPI is not required. Similarly, somebody is an anticoagulant. Just using anticoagulant alone does not mean you should give him PPI. If there are more risk factors, additional risk factors, then you should give prophylaxis. Same for NSAID. Very commonly, when we give somebody NSAID for pain relief, we also give one PPI prescription along with it. But it's not required routinely in all the patients. You only need it in patients based on the risk assessment and in selected patients. Okay. Another area where PPI is used prophylactically is the patients who are critically ill. We give it for stress ulcer prophylaxis. Here again, remember that everybody who's in ICU, HDU, who is critically ill does not require PPI. It's only required in a select group of patients. Because of lack of time, I cannot discuss the risk factor for each of the drugs. The guideline I just now showed you, if you read the guideline, it talks about the risk factors for different things. But I will just cover a couple of conditions which are important, one of them being NSAID, because this is one drug along which PPI is almost virtually always prescribed. But you need to give it in patients only if they have had any previous history of gastric or duodenal ulcer or a bleed. If they're taking multiple NSAIDs or taking something like an aspirin with NSAID, high dose NSAID, somebody's taking anticoagulant or steroid along with the NSAID, or in old patients. Those patients, the risk is higher, and there you may need to give prophylaxis. Otherwise, routinely with NSAID, you don't need to give PPI prophylaxis. Similarly, in stress ulcer, literature has shown there is too much of misuse of PPI in stress ulcer prophylaxis. There are well-defined conditions, indications where you should use it. For example, if somebody is on mechanical ventilation for more than 48 hours, somebody who's got a coagulopathy, low platelet count, deranged PT, deranged PTT, previous history of ulcer or GI bleeding, if somebody has a traumatic brain injury or a spinal cord injury, or a severe burn. So burn, neurological injury, previous ulceration, deranged bleeding parameter, mechanical. These are a few conditions where you would want to use PPI. Because remember, PPIs also predispose you to getting infections like pneumonia and C. difficile infection. And therefore, it may not be beneficial, but it may actually be harmful in patients if you use it indiscriminately. So definitely, if somebody is on a dual antiplatelet drug, there is definite role of evidence of benefit. It reduces significantly the risk of upper GI when you are on dual antiplatelet, but not on single antiplatelet. Similarly, for stress ulcer, I would like to again emphasize that for stress ulcer, PPIs are often used. PPIs have not been shown to have any mortality benefit instead. They have a benefit in terms of reducing GI bleed, but no benefit on mortality. Therefore, use it judiciously only if they have additional risk factors. So those were the prophylactic setting, the antiplatelet, anticoagulant, NSAID, steroid, and we talked about stress ulcer. Steroid also, if somebody has a risk factors extra, then only you should, otherwise you should not routinely give this thing. Next, we talk about some common conditions where we should be careful when you're using PPI. One of them is chronic liver disease. Again, we see a lot of prescriptions of PPI in patients who are having chronic liver disease. But in those who have cirrhosis, we should use it with caution because there is data, there's multiple studies now which show that PPI in these patients can increase the risk of infection like spontaneous bacterial peritonitis. And it can also increase the risk of decompensation. Patient can get ascites, bleed, etc. when you give this. So these drugs, patients run the risk of getting a decompensation or an infection if they get PPI. So you should be cautious in using PPI in these patients. Chronic kidney disease, we all know that PPIs have been found to have been associated with kidney injury, that is acute kidney injury. But what about those with chronic kidney injury? In chronic kidney injury, whether PPI makes the kidney disease worse, the data is very conflicting, but it's better to err on the side of caution. So therefore, if somebody really needs a strong indication of PPI, you can give PPI. Otherwise, you should not use it. Avoid indiscriminate use of PPI in patients with chronic kidney disease. Same in children. In children, the indications for PPI are same as an adult, that is symptomatic GERD, peptic ulcer disease, H. pylori, etc. But avoid PPI in less than 1 year of age because this group, there may be more harm. And that's why we say less than 1 year of age, try to avoid PPI. More than that, the indications are same as it is for adults actually. PPI in pregnancy. Pregnancy is one condition where we all want to be very cautious in terms of what drug we are using because of the risk of teratogenicity. PPIs have been generally shown to be safe in pregnancy. And there is not, there's no strong evidence that there is any teratogenicity. Still, we should exercise caution. In the second and third trimester of pregnancy, you can use a standard dose if there's indicated. But in first trimester, when this is a period of organogenesis, we should be more careful and use it only when there is a very strong indication and alternative therapy is not possible. For example, somebody has a GERD, you try a dietary measure, try a lifestyle measure, give them H2RS before you jump to PPI in these patients. This is a study published in NEJM which showed that PPIs are generally safe in pregnancy, but there are other case control studies as well which have shown increased risk of cardiovascular malformation, congenital malformation, etc. And all this we know happens mainly in the first trimester. So because of this, when we made the guidelines, we said that be careful in the first trimester, second and third you can use if there is a strong indication. So those were the special situation: liver disease, kidney disease, children, and pregnancy. Then we also give PPI generally when somebody is getting an antibiotic or a probiotic or bisphosphonate, we want to give PPI. So whenever there's an antibiotic prescription, below that there'll be one PPI prescription as well. But again, evidence does not support this practice and we should not be doing this in our practice. Why we are talking about all this stewardship PPI, two things obviously. One is the cost, the patient has to spend money on buying the medicine. And second, more important, is adverse effect. Now we know that there are several adverse effects which have a link to PPI use, and we have to be careful when you're using PPI. And I'll be discussing few of the well-established adverse events. One of them is higher risk of GI infection. So PPI has been shown to increase risk of certain GI infection, increased risk of acute interstitial nephritis, that is kidney injury. There is increased risk of hypomagnesemia, B12 deficiency, iron deficiency. The risk of bone disease, etc., is not very clear. Similarly, there are a lot of neurological conditions like dementia, etc., but the evidence is not that strong. So for infection, I told you, for example, for Campylobacter, PPIs increase the risk of infection 5-fold. They increase the risk of Salmonella infection by 4.8 times. They increase the risk of C. difficile infection. Multiple studies are showing increased risk of infections. Therefore, we should be careful with these with the drugs. Again, the risk of interstitial nephritis, the odds ratio is about 3.6 in those who are taking PPI. B12 deficiency, there was no good meta-analysis. So when we did the PPI guidelines, our group also did a meta-analysis, which we have published recently. And we have shown that there is odds of 1.4 to develop B12 deficiency when you take PPI. So again, the main thing is in GI infections, acute intestinal nephritis, hypomagnesemia, B12, iron deficiency, and other side effects as well. So this is my summary slide, the last slide of the PPI. So as I told you, overuse of PPI is common in clinical practice. So when you come across somebody who's having a prescription which says PPI, you find out why the person is using PPI. If the patient does not have a valid indication, try to stop it. You can abruptly stop it or you can slowly stop it. The defined indications of PPI are GERD, dyspepsia, peptic ulcer disease, H. pylori therapy, and for prophylaxis. For most of the conditions, giving it for 2 to 4 weeks is sufficient, sometimes up to 8 weeks, but not beyond that. Only patients who have severe esophagitis or peptic stricture, you give a long-term maintenance. Those patients who need for prophylaxis like antiplatelet, anticoagulant, steroid, NSAID, critically ill, these patients give it only if they have more risk, not just mere presence of the drug, but if they have some extra risk factor, that's when you should give this prophylaxis. Be careful when you're using it for patients with kidney disease, liver disease, pregnancy, and in infants. Routine co-prescription not recommended for those who are taking antibiotics, probiotics, etc. And be aware of the side effects like GI infections, intestinal nephritis, hypomagnesemia, etc. when you're giving these medications. So with that, I come to the end of my presentation. And yeah, cases we'll probably discuss after this. Thank you.
Thank you, sir, for an excellent comprehensive session on GERD and PPI. So we have some of the queries in the chat box as well as from the YouTube. I would like to ask them for you. So first query is that what is the role of levosulfide in the management of GERD?
Yeah. So as I was telling initially that, again, levosulfide is mainly a prokinetic drug, and what we told you initially is that prokinetics have a role in GERD, but not as much as the PPI or H2RA, because prokinetics only in patients who are having a bit of a volume reflux or those who are having impaired gastric motility, it can be given as an add-on therapy. Because again, these drugs, even levosulfide, can have side effects. People can get some other source. So the problem is the side effects with prokinetics and levosulfide is a bit more, and that is why we use it. But it can be used as an add-on therapy in patients who are not responding or those who have volume reflux or who have normal gastric empty. Yeah.
So one other point I want to add, Amit, just to add to your comment, that levosulfide is well known to lead to muscular disorders, neuromuscular disorders. A lot of patients, I won't say a lot of patients, but some patient develops muscle weakness or movement disorder.
Even hormonal issues happen with that. Hormonal issues, you can get the prolactin, all those things happen with. So that's why it's an issue with that. Yeah.
And also, one should be very cautious using in elderly people, because we have seen patients who developed intestinal obstruction after prolonged use of levosulfide. Therefore, levosulfide should be used with caution.
Yes. So that's why I didn't even mention about this drug, because really most patients, you don't need to use those drugs. If you go to the lifestyle, dietary measures, use PPI in a proper manner with the way I told, compliance and the timing before meal, etc. Mostly it helps those patients.
The second query is that what is the risk of carcinoma with long-term use of PPI?
So long-term use of PPI, at least there's no much risk in the esophagus, but there is some concern, some paper coming about risk of carcinoma in the stomach. And more, again, recently we had some paper like that. But thing is, these data, when they come from large database sets. And when you have database sets, many factors are not very well documented. And you don't know what confounders are at play in those things. But so therefore, as of now, even though there are pointers that there may be high risk of gastric cancer in this group, I would say evidence is still not very convincing as of now. And again, if you look at the use of PPI, what I was showing in my presentation was most patients need it for a short duration. If you give it for a short duration, there are very few patients who need PPI for long term. If you give it for a short duration, then I think the issue is not there. Long term, if somebody needs it, the risk is so low that if somebody needs, probably risk benefit may favor giving the PPI. If there is something like, say, long term dual antiplatelet therapy, or somebody has a previous GI bleed is on antiplatelet, you may have to give it in that setting.
The third question is that in a patient with well-controlled GERD on lifestyle, Is there any indication of endoscopic monitoring of development of Barrett's esophagus?
Yeah, that's very good. So I think that I did touch upon this in my presentation when I was talking about endoscopy. So if in our country, I said we go for alarm symptoms as main indication, and also those who are more than 55 years of age and not respond to PPI therapy. Barrett's in the Western country or in Japan, in countries where the Barrett's is high, adenocarcinoma esophagus is high, definitely there is a role. But in our country, as of now, we still sort of don't have a good community-based data on Barrett's. The hospital-based data shows that Barrett's is it's there. It's almost same as what we are seeing in the Western thing, but we don't have good community-based data. So therefore, as of now, we will say this is more like individual doctor or practice-based actually. But if for Barrett's, what they say, if somebody has a GERD symptoms for more than 5 to 10 years, somebody has a documented hiatus hernia, somebody is obese, somebody who has a family history of Barrett's esophagus, adenocarcinoma esophagus, these are the patients who would need to be an endoscopy surveillance program. But whether we should do it in India with the amount of the cost factor involved, availability of equipment involved, whether it's practical in our population is something which we are not very sure. Western country, definitely yes. But for us, probably maybe if the patient can afford and you explain to them, if somebody wants to be on a thing, we can offer it actually, I would say. So case by case basis, we can do it. Dr. Govind, sir, you want to add something to that?
No, it's perfect. This is a perfect answer.
That's what I think we do for our patients right now. We go more practically rather than a blanket approach for all the patients actually.
But it's important that earlier we believed that we don't have Barrett's in our country.
Yeah.
It's not true.
Yes.
That not many patients who have in our country do have Barrett's esophagus. But how to follow them up who are patients who screen for Barrett's esophagus, I think to work on that. I mean, this may be a next question for our task.
Of course, yes, definitely. I know Barrett's is something which is still, we don't have much for Barrett's in our country as of now. Yeah.
Then another question is that in a patient with the hiatus hernia with significant symptoms and not willing to undergo surgery, is provide PPI for long term.
Yeah. So see, as I told you, if somebody has a hiatus hernia and you're giving PPI, if symptoms have responded and if he doesn't have a severe esophagitis, you can actually stop therapy. And if he has recurrence of symptoms, you give it again. But if somebody has a large hiatus hernia, grade C, grade D, severe esophagitis or a Barrett's esophagus, those patients may need to take PPI for longer actually. So again, just mere presence of a hiatus. In fact, when you do endoscopies every day, we see quite a few hiatus hernia who are asymptomatic. Patients themselves don't know that they have this condition. And then it takes us some time to tell them that this is not like a normal hernia you get in your abdominal wall or something else actually. So hiatus hernia is not always a symptomatic thing. Look at the hiatus hernia, look at the presence of symptoms, look at how much injury is there in the esophagus, and then decide on how much you're going to treat. If there's no esophagitis, you can give initial therapy and then on-demand therapy. Severe esophagitis, you can give a long-term therapy is what I would say.
Another question is that in patients with CKD with GERD, is it better to give H2 receptor antagonist than PPI, sir?
So H2 receptor, again, they are good drugs. So if somebody's symptoms are infrequent, like, he's getting once a week or once in 2 weeks, like those symptoms, H2RS may be good actually. But if somebody is getting frequent symptoms and in those patients, so again, like there are two approaches in GERD. People, they call it as a step up and step down approach. Step up is you give the PPI straight away and then try to come down, maybe give it H2RA, etc. And so that's step down. You start with higher and come down called step down. Step up is start H2RA, go with the PPI, increase the dose, etc. Actually. So I would say you can try with H2RA, but if the patient needs PPI because of significant symptoms, we should give it because in kidney disease, the data says it doesn't really accelerate the progression of kidney disease so much. It can in a chronic kidney disease patient. So I think if there is a real need to give it, we can give it, no problem.
So this is the last question. This is from my side. I am a senior resident in geriatric medicine. Yeah. So half of our patients come with GERD symptoms and dyspepsia in our OPD. And most of them have inappropriate prescription of PPI for really long time. And along with the polypharmacy and delayed gastric emptying, and with that, they have something like PPI dependence. If we stop the medication and then start to complain of having reflux disease, and it affects their quality of life as well. So what are we supposed to do regarding this?
No, very true, and very practical problem which all of us face, because once these guys are used to long-term PPI, stopping is always a problem. And people have looked at how to stop PPI in these guys who are on long-term actually. Unfortunately, there is only one randomized trial looking at suddenly stopping versus slowly stopping. They did not find much difference, but that trial was not powered well enough to look at that outcome. What I would suggest in practice is that you should go with a step down. There are different ways of stepping down. One thing you can do is, supposing he's on 40 milligram of say one drug daily, you make it alternate day first, okay? Or you can make it 20 milligram. This thing, do it for about 2 to 3 weeks like that. Then you start to increase the thing, and so maybe you can first make it alternate day, 40 milligram alternate day for a month. Then you can make it 20 milligram alternate day for a month. Then you can stop it. If not, you can add an H2RA at that point, stop PPI, switch to H2. So you can switch to H2RA, reduce dose, make it alternate dose. There are different strategies to try. But with that, I think about 70 to 80% of times you will be successful actually if you try it slowly like that. Because initially there is this phenomenon, what we call as rebound as hypersecretion. Because the stomach is so much used to PPI, the gastrin is not working, the pump is blocked. So more and more gastrin is being produced. So once you stop, suddenly there may be a rebound acid hypersecretion. And therefore, I think in these patients which you spoke about, maybe try to taper it slowly, maybe give it alternate day, make it half dosing, switch to H2RA, and then give it about 2 to 3 months time. And I'm sure in about 2/3 of them, you will be able to come out of the PPI prescription.
Thank
I
you, sir.
want to add one more point in response to your question, that what happens in elderly, they go to multiple departments, cardiac, neurology, orthopedic, and each one writes PPI in their prescription. And therefore, patient, if not so aware, he might be taking one pantoprazole, one ribiprazole, or maybe ranitidine in addition. Because each prescription will have a PPI, and we don't have a system to have a composite prescription for one individual. So most of the time, they're doctor-based prescription. Therefore, there are 3 prescriptions from 3 doctors. And therefore, many patients might be taking double dose of PPI, which are not required.
Yeah, true. That's very true. I think so. So PPI is like, when we made this guideline, we realized how complicated and how intricate and how what to say. It is really, deep rooted into a system of prescription across all specialties, not just gastroenterology, across all specialties. Yeah.
Thank you, sir. Sir, now I would like to call upon Dr. A.K. Sood, sir, for vote of thanks. He's the Deputy Secretary of NAMS.
Thank you so much.
Before Dr. Sood, I must thank Dr. Amit. I think this was a wonderful lecture, very simplified on a very common disease. And you also talked about the PPI stewardship. And I think all of us should think that what are the real indications of using PPI, and always for short duration, 4 to 8 weeks. We might give one more course later, but there are only few patients who require long-term continuous use of PPI. I think all of us must be aware about, must think that how do we decrease use of PPI in our patient.
Very true.
Thank you, sir. On behalf of the National Academy of Medical Sciences, it is indeed my great pleasure to thank the distinguished expert for this evening. First of all, I would like to thank Professor sir for sparing his valuable time and covering this topic very comprehensively. And I'm sure that the participants have greatly benefited. Thank you so much, sir, for your support. Our thanks to Professor Govind Makhija, sir, for being with us throughout and also helping us in identifying the best speaker, as well as the talk. Thank you so much, sir, for your support to us. We look forward for your blessings in future. I will also like to thank the participants for asking the question and making this session so interactive. In the participant, we were privileged to have the Director AIMS New Delhi. He was with us. So thank you so much, sir, for your presence and your message to the participant. And your presence is of great encouragement for all of us. We look forward for your support in future also. The next AIMS NAMS Navigate session is due on 1st of December. That happens to be first Friday at 3 p.m. And here again, we are going to have very interesting common topic across all specialty, where Professor Meenu Singh, who is Director AIMS GKC, is going to cover evidence-based medicine. So I will request all the participants to please be available for that session also. We are going to send you the details of Zoom link. Then another announcement is that we have now linked with the Association of Physicians of India, and they have kindly agreed to have a joint CME session, which is on second Friday of every alternate month, and on 8th of December at 7 p.m. we are going to have a discussion on very important topic of heart failure, where the distinguished expert from Association of Physicians as well as National Academy, they will give you the important tips and share their experience how they manage these things along with the recent advances. That is again going to be that is on 8th of December, and the timing is 7 p.m. in the evening for 1 hour. And last announcement is related to the next session in the series of gastroenterology, which happens to be on 15th of December. That is again 3 p.m. And again, very interesting topic is irritable bowel disease, which we are going to cover. And thanks once again to Dr. Mafija sir for selecting the best topic and the best speaker for us. In the end, I would like to place on record the support which we have been getting from Dr. Jaswant. And now this evening we are privileged to have Dr. Akshita with us, who helped us in organizing and moderating the session. Thank you so much for being with us and for your. I will also like to place on record the support which we are getting from our IT officer, who is with us. Thank you, Raviji, for organizing and sending emails and. And then once again, I'd like to thank all of you for being with us and making this evening very interesting and learning experience. Thank you. Good evening.
Thank
Over
you.
to you.
Bye.
In conclusion, this CMA session on GERD has provided valuable insights into the latest diagnostic and treatment approaches to one of the most common conditions which we see in and day out in our OPDs. As healthcare professionals, let us apply this knowledge to enhance patient care, stay committed to continuous learning, and ensuring optimal outcomes for individuals affected by GERD. Thank you all for active participation and dedication to advancing medical practice. Thank you.
Okay, bye-bye.
Bye.